promote. Dave Obert for Vancouver. So again, these are the medical directors for the largest cities in the United States, and it covers about a third of the US population. So we don't look at that as a bragging thing. We look at it more as like we're not, we have a huge responsibility and accountability. And that's why this meeting that we have that keeps everybody usually several steps ahead of the game has been invaluable to them. So I don't know. I'll just look up and see Dave Miramani's, for example. You're on just about every week, but you're one of the people I consider to be one of the more progressive people, in emergency medical services. What is your take on this meeting? Why are you on every week? Because you're very knowledgeable about emergency medical services. We always look to you, in fact, for your opinions on things.
So every week I get a little nugget that's something I can either teach in my classes, change a protocol, or investigate further to see if it fits our organization. Every week I get my batteries charged about EMS. And I think also I get a lot of intelligence. Like when Crawford starts talking about opioids issues he's having in Philadelphia, I get intelligence that I can use in my organization about some new additive that's going in the drug supply, for example. So
you're saying that now you're looking for it that you weren't looking for it before.
Oh yeah, exactly. And then during COVID, this was just invaluable. I've learned so much about infectious disease stuff from John and Smarty Marty that I never did in medical school. I mean, seriously, it's really been a great experience for me. And I'm old and cranky, and so anything that can get me up in the morning and get me learning is great.
Yeah, let's say I just see then right next to you, I see Jim Augustine's up there. Jim, so just so you know, Jim has not only been, he's got a couple of cities himself that are large cities, but Jim has been at this. He's had in the past, he had Atlanta, Washington, D.C. I could just keep going on, but he's currently the medical director for the International Association of Fire Chiefs and all that. And Jim, how's this been for you?
Paul, this is 5 years of this conference as of this month, and
okay.
there has been no better way to survive and frankly thrive over the last 5 years than a weekly recharge with this group. As Dave pointed out, this is worldwide intelligence that relates specifically to what we do as EMS leaders. It recharges me just like my Diet Coke does. Dave's got his coffee. We have all needed this, and then what we do then is multiply it. I do through the International Association of Fire Chiefs, International Association of Chiefs of Police, and our other local contacts that then extend out. So there's no better hour and a half of CME that has occurred every week for 5 years than doing this. Thank you, and thanks for leading it.
Now, Jennifer, you have you have a responsibility because you have to make sure that we're following guidelines, et cetera. And so as you'll see here, as we roll it out today, we'll have someone stimulate a thing, but then we'll then comment at it, and everybody will give their perspective of what they're seeing, if that, helps at all as we go through this. Let me see who else I've got on the panel here today that has been with us for a long time. So this is a good example, Eileen Marty, okay? Eileen Marty is from our neck of the woods, actually, Jennifer. She's an infectious disease expert, but more than that, I knew her from years ago we were starting Homeland Security issues and working with the national security agencies back in the early 2000s after 9/11, and she was right there helping us with various issues, particularly weapons of mass destruction and particularly bioterrorism. And so we were very fortunate. I saw her on television and I said, I got to have her get on this group because she can fill us in every week on what's the latest happening. So we knew about measles before it became an issue that you heard about. We knew about, for example, the loss of taste and smell long before anybody else really knew about it on this meeting. And then we got the word out to 250,000 paramedics who cover a third of the US population within a matter of 24 hours, which was just fascinating. And then, but Eileen, I brought you on originally as a consultant to fill us in on whether it was COVID or whatever else, but you're on every week yourself. Why do you do that? Do you learn anything here?
I learned so much, and I love your perspective on how to manage patients. It's absolutely critical and gives me insights that I wouldn't have in my routine type of medical practice.
So that's great. And then the thing is that, and one of the things that David Mirmani said was that he learned so much, for example, from her. So this is a great exchange that goes back and forth. Again, it's a kind of a panel format versus our usual lecture format that one would have, although occasionally we'll have someone come in and give a brief presentation, but it's usually there to stimulate discussion amongst everybody and what their experience has been. So and by the way, we have people from across the planet. So Fiona Moore was the executive director and the medical director for the London Ambulance Service, and she's one of our emeritus members, but she's hung on, right? Like Fiona, and why is that?
It's being part of a family, I guess. Paul, it's been a huge privilege to see what happens across the pond. And for me, having transitioned from running a big ambulance service to working in the air ambulance fraternity, it's a really useful way of keeping grounded in what's happening, if you like, in the real world, with lots and lots of patients with a huge variety of presenting complaints. But it's also just great to stay in touch with people who I regard as being friends.
Fantastic. Yeah. And then let's just jump over across the pond then to Glenn Sada in New York City. So no one sees more. How many patients do you deal with a day in New York City on the average, Glenn? What do you see out there in terms of the 911 system?
Yeah, we usually like to say 4,200, but we're actually 4,800 a day.
Yeah, so nearly 5,000 patients a day that you have to deal with and you're responsible. And you've been doing this for well over a decade, right?
That's correct. Yes.
And yet, so who else could be more knowledgeable about this thing than you with all your experience? And yet you're on every week as well. And why is that?
Well, it's interesting because, I get on every week just envious of everybody else on this call that can do so much within your systems. I try to get as much as I can, and realizing how large our system is, and with politics like everyone else, how difficult it is to get certain things done. But not only do we try to get cutting edge for pre-hospital, out-of-hospital care, we also get a lot of information about what can we do for the safety of our members to keep them safe. So we get a lot of information in that regard as well.
Yeah. And different people have different perspectives, and you'll have someone like myself or David or some of the other, or Rob Dunn, who can't make it today because he's at a state meeting. Will always learn something every week that will change, or it's a different perspective. Go, that's a great way. I got to remember that, so it builds upon each other. It's kind of a building block that we get out of these discussions every week and all that. Let's go out to LA County. Clayton, do you get anything out of these meetings? You're on every week, so you must do it, right?
No, I get nothing. No, I was just thinking I was reflecting yesterday because the New York Times Daily did a piece on, I guess some researchers from Princeton published a book about the pandemic. And I was just thinking about, there's so many different sources of information that were out there during the pandemic, and you didn't really know what was just people bloviating in the news and what was actually real. But getting on this call every week, we could hear Paris was surging, so we knew something was coming before it ever hit us. And then we also knew things like monoclonals and stuff were getting a lot of real success. And so knowing kind of what we needed to implement, what was coming to us, and being able to share experiences about, the challenges we faced in getting our ambulances offloaded and all that was really, really helpful. So no, I really enjoy and get a lot of value out of being with this group each week.
And everybody has a different perspective, and that's what's really nice. So for example, you might be talking about ambulances that waiting in the emergency department, call it wall time or call it whatever it may be, where they're stuck, they're waiting to offload the patient and they can't. And how different people solved it, such as, the guy from San Jose says, here's what we did, and so on, etc. And then you also find out that worldwide they have the same problems. Mick Malloy, for example, who works out of Ireland, and he lives in Dublin area, and Mick's on with us every week. And what do you get out of this, Mick? Because you've been at this for decades, right?
Well, I think it's the different perspectives that, you think all your problems are very unique. You find out many people have the same problem, but have approached solving it a different way.
Right.
And when you look at the bigger picture, then you go, I could do that here. And I could see how that could make a difference in our solving it. And as you mentioned about the emerging infectious diseases, being on a call like this and suddenly finding out there are explosions of activity happening around the world can warn you to get ready in your system before it becomes news.
Yeah.
And then you've got the other innovations. I mean, sitting down here looking at your own head up CPR. I mean, that stuff is incredible. Like, we would wait years to see that in conferences, but you're getting that first up here.
Yeah, that's a good point. We like the blood thing. We really helped get the blood across the United States because of this meeting. So it just is a good example of that. I'll sort of let me just take one last perspective. I saw Jacob Nocht here, who just started with us. And Jacob, you go to CME meetings, or you did before, et cetera. What's the difference here? Why are you here every week?
Yeah, hopefully you guys can hear me. I mean, I think for folks like myself who are very new to this group, but also relatively young in the medical direction world, it just provides a group that I can come to with issues. I think somebody said it earlier. You think you may be dealing with something that is new or novel or nobody else has solved, and you come to this group and say, hey, has anyone dealt with this? And by the end of the meeting, you have 7 emails with some ways to solve things and ways to deal with things. And, and just more generally, somebody just to chat through things and kind of manage the stress and the challenge of it. So that's kind of been the biggest piece for me, is just is a community and a practical group to be able to help work through things that you're not the only one dealing with.
Yeah. So I won't progress. I think you got good enough feedback there, Jennifer, to sort of see a little bit about what it's about. My summation is that one of the things we have found, and why everybody is here, is that a lot of times if you go to a meeting, or if you go to a committee meeting, or if you go to a CME thing, you have someone talking to you, like they're the expert out there talking to you. Everybody on this call is an expert. They have to be the expert for their local jurisdiction, and boy, do they have to be. And so as a result, and what I really like about this is that there isn't a lot of people being pretentious or talking down or trying to prove that they're smarter than you. And we have a lot of people on this call that are definitely smarter than me. And yet you just feel like it's a safe zone, and it's a great environment for learning, is what I hear. And you see also it creates these friendships, this camaraderie. It's kind of what's been kind of cool about this. So I just wanted to have you sort of get a vibe or feel that this is a unique learning kind of I don't know what the right word is, approach or environment, a learning environment, but it's an accelerated learning environment, and it keeps you way ahead of the curve on everything else. And that's sort of my summary. Anybody else want to pipe in and add to what I just said, or and then we'll see if Jennifer, if you have any questions for us.
No, thank you.
Well, we lost your voice.
Thank you. We appreciate the update and learning what this call is all about, and it's great to hear all of your feedback. And we really do appreciate the feedback.
Yeah, it's good. And then I hope this helps you feel better about, that why this is actually is an extraordinary learning experience, and why it's really a more of a progressive form of continued medical education for me, because it's really invaluable and it's useful, and you do change practices as a result. That you kind of got that inferences from, the people that you just heard from. Okay. And I'm going to tell you, they're all brilliant, the people on this call. It's fantastic. So please feel welcome to sit in. Before I go to the I think we're going to have a talk about the survey on brains on stroke. I wanted to let everybody know a little bit about, let me see, what was everything I was going to talk about here real quickly. Oh, let me just quickly say, Eileen, anything we need to know in the infectious disease realm, or we could talk about later in this session, know that, or, but do you have any quick tips for us that we should know about for this week?
I think we should write to our congressman and ask not to let bird flu run wild through our birds. That's just an absolute recipe for allowing the virus to mutate in many, many additional ways, not just in birds, but in birds, animals that are infected by the birds. And so we're running into a huge, huge problem there.
So you're saying you want to do this through legislation, et cetera. So if I called my congressperson and said, so what am I telling them we're supposed to do?
I think you need to encourage them to encourage the head of DHHS not to go through with the plan of letting bird flu run wild through the flocks.
Okay, got it. All right, and now, do you anticipate that there'd be pushback on that? For example, because you're hurting the industry or whatever, and they're more interested in helping out industry versus public health? Is that an opinion you have, or what do you think?
It's not about opinion. It's about they have this notion that the Darwinian, that the strongest birds will survive with, and that's very uninformed because the virus mutates. It's not a one-way proposition, right? Yeah. And influenza, because it's 8 separate strands of genetic material of RNA in the genome, has a much higher propensity for recombination and forming completely new, much more dangerous forms. So when you let it run wild, you're not just putting more birds at risk, you're putting more mammals at risk, and that includes humans. And that's something we want to avoid. And I see something by Joelle asking.
Yeah, before you go to that, let me go to John first on that, then we'll go over to the measles, okay? John Chu, anything you agree with that, or do you have a differing opinion or a different perspective?
I agree. Anybody that has studied influenza, the largest danger is a large vector area where there's multiplication of flu virus. So completely agree. I think, honestly, I think the greatest threat to our nation, and actually the world, is a mutation of flu, perhaps bird flu as well. So, so the answer is I agree completely with Eileen. That's the greatest threat in this year right now.
Okay, and then and I just want, for everybody else's purposes, and particularly for Jennifer and her team, that John Ju is not only the medical director for Portland, has that responsibility, but also is an infectious disease specialist as well. So we're able to get the translation from not only just the theoretical, but what we're doing on a day basis. So, for example, go ahead.
Sorry, Paul. There's one political issue here.
Yeah,
bird flu will spread into Republicans, Democrats. You know what? It doesn't really matter which household. Most importantly, it'll spread to your pets. Does that make sense as well?
Yeah.
So the point is that it doesn't has no political boundaries, and this is a general a population thing, including animals as well as humans. So this should be an apolitical issue.
Yeah.
And Paul, I have to go because I have to do an exam review for my students, and I do want to answer Joelle. I did give a measles update a couple of weeks ago, but it is time for another one, so we can discuss that for next time. But I got to go. Always a pleasure. Wish I could stay.
Yeah. And then okay, good. And then John can continue. John, want to go back to what we talked about a couple of weeks ago? We were talking about practical levels in terms of what we do with our troops, like in pregnant women or kids or whatever. What are some of the advices that we had in terms of well, I guess one is a generic. I think the question is, what are we doing for our troops specifically? But then I think that there is more to be said in terms of just in general. I think she wants to get. Is that what you're looking for, Joelle? Joelle's out of San Diego, by the way. Jennifer and all those were there. Joelle, are you specifically wanting to learn about measles or what we should be doing for our troops, or both?
more of like an update on how bad the spread is and what it's going to take from an ID perspective to get it back under control. We had it eradicated, and now it's in numerous states, over 300
Yes.
cases. Literally, how do we get it back to being eradicated? What are the steps that are needed?
Yeah. Okay. So yeah, we did that in some detail over the last couple of weeks, and we can go back and do it again next week. But John, do you want to do the quick?
Yeah, I think the problem, there was actually three things. From a operational point of view, my greatest concern as an EMS medical director is basically occupational health, to make sure our EMS care providers are vaccinated, or in other words, it could take out a whole shift. Does that make sense as well? The second thing, so you should get all the vaccination records of all your personnel, especially with measles, and know who's been vaccinated with measles, who's not been vaccinated with measles, as well as people, your EMS providers at risk. In other words, pregnant people and people with multiple sclerosis and things like that. The other thing that we have,
John, let me interrupt you
Yeah.
for a second. So a couple of things that we also said is that if you had the actual measles itself as a kid, whatever, some of us elderly people like John and I and Eileen had it, and we're really protected from that. That's number one. However, those between 1960 and 1980 who got vaccinated didn't have the original disease. They probably need to be revaccinated and boosted, we're thinking, right, John? And then
yeah, if you only had one vaccine, we probably would recommend boosting as well. Okay, so the vaccine is very effective and it's very safe in spite of what all the hearsay has been talking about as well.
Okay, sorry to have interrupted you. I want to make sure she got those points as well, because we talked about the vaccination records. I thought that was really good. Okay, so go ahead.
The second real issue that we really haven't talked about is a measles case will shut down a hospital, or the ER. In other words, it stays in the room for 2 hours. It's one of the most infectious disease. And if you have a measles case, so basically the entire ER is quarantined until you can actually figure out what's going on. So you could lose your pediatric hospital. I'm looking at Joel right now with the measles here as well. So for a day or two, and that could be catastrophic for our patients here as well. So that's the second issue that we have. Regarding Joel's comment, it's going to be really hard. The only real way to do this is ring vaccination. In other words, in the family, with primary, secondary, and tertiary. Unfortunately, Oregon, especially Southern Oregon, doesn't believe in vaccines. So we have a large percentage of unvaccinated individuals, especially with parents with younger kids. So I think we're at risk, and it's going to, unfortunately, I think it's going to spread until it quote unquote dies itself out.
Yeah. All right. So Mick was asking you, do you have a specific recon protocol for measles? When you say recon, what does that mean?
That means I have fat fingers. It should have said decon.
Oh yeah. I was gonna do something I don't know, right?
I thought it was some weird Irish spelling, Mick, as well.
Exactly right. Okay, yeah, we're looking for measles out there. Okay, so yeah, the testing devices out there.
Yeah.
So what's you got an answer?
Measles is in other words, it can be on inanimate surfaces. So the usual decon methods would work here as well. The major problem with
kind of like what we did for COVID kind of thing.
Yeah.
Okay.
The major problem with measles, it's airborne. Does that make sense as well? So your HVAC system, especially in your hospital, needs to be very closely watched here as well. So you can take care of the inanimate object with complete decon, but you need to basically circulate that air for at least 2 to 4 hours to make sure that the air is gone and it's the place is clean. We had a measles case in Oregon in one of our pediatric hospitals. They shut down our pediatric for 4 to 6 hours as well.
Okay. So before we leave the ID thing, anybody else have any other questions or comments? I do want to go out to Libby real quickly, and for Jennifer and her team and everybody else. Libby Char was the Secretary of Health for the for the state of Hawaii up until a couple years ago, but she's still pretty much in touch with what's happening with public health out there. So Libby, tell us a little bit about what you said about an article about the chickens these days.
Yeah, just with regards to letting all the birds just get bird flu, and that'll sift out who the stronger birds are, and they'll survive. There's an article that chickens are bred these days to all be the same. So your egg layers and your hens for consumption there's really not anything to sort through to see which birds are stronger because they're all bred to be identical.
Okay. So you don't get for bracket, you don't get flock immunity. So sorry
If
for that.
only.
Joe. Yeah, yeah. All right. So all right, yeah, we had enough infectious disease for today, or is this okay? Joelle, does that satisfy what you need to know?
No, not really, but it's okay. So, it's more of so I'm very familiar with. As I said one of the last ones, I've been through 4 different measles outbreaks, but it
Yeah.
was in a very different setting where we had the resources and the government's attention to really lock down the measles spread, and I've never seen the rapidity of the measles spread as it's going, and so that's more of a. I'm trying to look at if it's not cracked down on. What are
Yeah.
we expecting over the next 2 months, 6 months, 1 year? How bad is this spread projected to be? Kind of like a forewarning of what's to come, kind of like what we did with COVID.
Yeah. Hey, Joel, it's going to spread. There's no way that we're going to be able to stop this spread because it's in multiple states right now. It'll spread in populations with low vaccination rates. That's where I would, if I was a public health person, be very careful. You can probably contain the measles in a ring vaccination or basically quarantine issue. But if it's in multiple states, it's like COVID and flu. It's hard to stop.
Yeah, so
answer
it's back to that, like, so how do we actually get that done and like in a coordinated approach? But I think that it's probably better for like a different day to hit it more.
Public health measures. We can talk about it offline on that issue.
All right. The last thing was that there was a question that came up from Fiona about COVID and COVID shots. Then they probably do lose a lot of us have been pretty well vaccinated over a period of time. If you have been, you're relatively protected. You won't get as ill, but you still could be. And we know that sometimes your immunity does go down for a while. So she was even saying for us elderly or people with immune compromise, you might get it, every 6 months, or you might, do another one now, et cetera, if you already had one in the fall. But in general, we're not quite doing it. But maybe once a year we need to do it. I don't know, for the average person. John, what's your opinion?
There is 2 or 3 articles that came out in the last 3 months that multiple vaccinations, especially in the older population, decreases long COVID remarkably.
Yeah,
okay,
that's
so
the issue. Yeah.
so the real reason for getting multiple vaccination is long COVID, prevention of long COVID. And I'll send the references out to this group here.
All right, good. All right, let's move on. Hey, Will, how are you doing on time? Can you hang in there for a while if I go to the other thing, or do you want to give your presentation?
No, I'm good.
All right, good. So let's get on to this thing I wanted to do about, I've been, the society that does interventional neurology, the ones that go and suck out your clots during stroke, want to start working with us closely and aligning things, and they're being very proactive, and have asked us to join with them. The first thing they want to know is how many people are following the guidelines. Probably most of us are that are on this call. The guidelines that have been put out about when you go to a comprehensive center or if you're in a rural area or whatever. And so they wanted to get a quick survey. When we got the original one they sent out had like 50 different questions on it, and just Peter, I think you sent it out and to like 132 people. And how many replies did you get because it was so long?
Not many.
Yeah, right. So the point is that we looked at it, and Jim Augustine and I and a couple others, David Miramontes, looked at it. We just said, just cut it down to what you really want to know, and then we can always then come back and do a secondary thing and drill down more, especially after what we learned on the first one. And so that's what we did. And then Kita, have you seen the updated version of what we were trying to do? Tell us a little bit of who you are and why you're doing it.
Yeah, and sorry, I'm on a plane right now, but so excuse any of the background noise. But first of all, I want to say I liked listening to all y'all's comments at the very beginning of the meeting. It's cool to be in a room with a bunch of Dr. Robbies. If y'all have seen the pit, so yeah. So basically we've cut down the survey now to 6 questions. So it's very, very short. I went through it myself. It took like literally less than a minute. And I think it really goes down to the essence of like what we're trying to understand, which is like, are we getting people to the right type of comfort, like stroke center based off of symptoms?
Right. So what I'm going to do here is to say, here's the plan. We're going to look at it today, and we're going to see, would you add something to it or change the wording on this? And then we're going to send out to this group, and we'll probably get a 90% response. And that means we're covering about 100 million Americans, that kind of thing. Then the next level after that, based on what we get back, we can maybe, tweak it a little bit more, the survey, right? And then we hope to send it out to a broader group of people, other medical directors, for example, through NAMSP or whatever, and then get you even more data. And what we're going to see is we're going to try to break it down to the rural people who have a rural distribution or jurisdiction versus those in a area where they may be more urban, where you can probably find a comprehensive center pretty quickly, that kind of thing. So, let me see. I'm just trying to see what Chris Colwell said. He said, have to hop off. Everyone losing their minds here, perhaps rightly so. Oh, I see. Okay, got it. So any event, so what I'm going to do is run through it. What we're going to do is we're going to send out a video first. So let me share real quick. Okay. Where's the share thingy here? Okay, here we go. And so here we go. Let's see if I can find it now. The survey of EM here. This is kind of what it looks like that the survey you'll get. It says survey of EMS medical understanding stroke protocols and destination triage. Blah, blah, blah. Okay, so there's the purpose, etc. So I filled in my thing here. First, we're going to show you kind of an overview, and this is something that Peter put together. And I said I'm Rocky Seashores here. Okay, and I'm in a state of mind. But any event, but here we go, and we'll go through it. And then after we show this, I want to take you through the current thing, and I want you to know, would you change the wording or add something to it or delete something? Okay, here we go. And let's sort of play this first. Oh, I got the wrong one. Is that because that was, I wonder how that happened. Because I had already done it before, Peter. You think that's what it is? Now, how do I stop this? That's what I don't know.
I would just go back on that link and then no, next one to the left of it.
Okay, that one here.
Right there, yeah. And then press the back button.
Yeah. Okay.
You do that too. Okay, fine.
Yeah, what I need to do is I got to go to. Oh, you know what? He sent it to my whatever this thing here. So, is that it up there? There it is, right? Okay, there we go. All right, now here we go.
There you go.
Hey everyone, it's Dr. Peter Antevi. We're doing a survey through Florida NAMSP with my good friend, Dr. Rajesh Mehta, who I work with closely here at Memorial Regional Hospital. They're looking to see the medical director's knowledge of stroke triage. Basically, where do you take stroke patients from your EMS system into what hospital do you go? And are you familiar with the guidelines? So Dr. Mehta, would you mind explaining what these guidelines are? And then hopefully people will fill out the survey after that.
Absolutely. Thanks, Peter. So back in 2014, 2015, when thrombectomy for stroke became scientifically proven as a standard of care, specifically for the most severe strokes, the large vessel occlusion strokes, or LVO, it became imperative to ensure that paramedics in the pre-hospital phase had a good understanding of where to take patients from field, get triaged to the most appropriate center capable of providing prompt treatment, the thrombectomy. So in 2021, the American Stroke and Heart Association came out with the pre-hospital destination triage guidelines in order to better guide paramedics who may reside within their communities, such as urban, rural, or suburban areas, to the most appropriate type of stroke center, whether that is a comprehensive stroke center or a thrombectomy capable stroke center when they suspect a large vessel occlusion in the field.
All right, so if you can take a few minutes, fill out the survey, it'll evaluate medical director's knowledge. We then plan on taking this nationally to the national NAMSP, but the information that you provide us is very important and it'll help us improve the care that our patients receive in the field. So thank you so much, and Rajesh, thanks for joining us.
Thank you, Peter.
So Peter, that's such cool music. Thank you for watching and doing this. Here we go. So, all right. So then it goes, okay, then you fill in your name and your state or whatever it might be. And then, so then it shows these EMS guidelines. You can click to review them if you want. out there, right? And then, so here's your first question. Are you familiar with the ASA designation triage guidelines? So it's yes or no, right? I guess. So I'll just say yes arbitrarily. I'll just answer this, right? Has your agency implemented one of the ASA triage guidelines shown above? So I'll say, okay, yeah, yes, all right, just for fun. And then it has here, which ASA triage does your agency currently follow or would follow if implemented in your region? Okay. Does anybody have any problems with this? Because I think this goes back to the guidelines, and Nico, you could probably confirm that with me, is that they said an urban population, do you live in a place that has your jurisdiction, I guess, that you work at, says your agency currently follow, and I think their jurisdiction is in an urban area. Let's say, yes, I have that. I also have a suburban area, so I'll check that as well. I don't have a rural area, so I'll leave it at that. Does anybody have any problems with these numbers or understand that they came from, whatever guidelines that were written before? Any comments on that? And Keita, anything you'd add to that? Is that a basis for putting these numbers in there?
Yeah, those were from the American Heart Association guideline, like how they defined it.
Okay, got it. All righty, that's it. Anything, we talked about this before, Jim Augustine, anything, is this okay with you now, understanding that?
Understand.
Okay, good. All right, so then which stroke severity scale is used by your agency pre-hospital say? Okay, I live in San Antonio, so I use VAN, okay, that kind of thing. Are there any places that use more than one? That's the other thing. Or are you using maybe a race with cortical signs, right? Something like that. I'm going to put that in there.
Make sure that you can reply with more than one, because it doesn't look like currently you can.
Ah, interesting. Okay, got it. Because you could be using different ones, right? Is that correct, you think?
That's correct.
Okay. All right. So did you hear that then, Ankita? So we can get feedback to them, right?
Yes, I'm noting this.
Okay, good. Okay, here we go. Does your protocol include triage decisions based on stroke severity scale scores? Okay. Bypass, blah, 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 blah. So let's say yes, okay, for me here. Does your protocol specify a maximum transport time to thrombectomy capable comprehensive stroke? I'll let you read that and see if you have anybody have any comments about that. Okay, so I'll say maximum transport time. I'm going to say no, we don't have a maximum transport time. We just go there, I'll say, in my situation. All right, so go ahead. Next. And then it says, and this is where I really want you guys to pipe in. What challenges has your agency faced or would encounter in implementing the ASA designation triage guide, if any? Okay, select all that apply. So lack of first responder awareness or training on the guidelines. Okay, I don't know if you had that or not. Resistance from first responders to adopt new guidelines, kind of a common theme, right? Inconsistent or unclear hospital capabilities. Okay. And we faced that years ago. I remember in Florida when we first started doing this. Limited availability of thrombectomy capable and or comprehensive stroke centers in the region, which may be particularly applicable to those who are the rural areas. Okay, maybe not so much for us. And difficulty coordinating with hospitals during transport. I wasn't sure what that meant. Does anybody think they understand that? Is that pretty clear to them or not clear? David, are you able to see that, by the way? Because David Miramontes, I don't know if he's on the phone, so too bad. Resource limitations, okay, staffing, ground air transport, hospital pushback due to under or over triage, because we hear sometimes the complaint is that you bring us too many people that don't really have stroke, because stroke is such a, I had actually made the suggestion to say that there was such heterogeneity of the presentation of stroke that you might get pushback doing over triage or under triage because of that. Jim, you made a comment about that, right? At one time, should we change this or is this okay like that?
Yeah, I think it's as good as you get.
Okay.
I don't understand that they want difficulty coordinating with hospitals during transport.
Okay.
That make a lot of sense, and I don't think you're going to find a lot of people respond to that.
Anybody want to comment on that further about difficulty coordinating with hospitals during transport? Is that a communication issue, or do we understand? I'm not sure, is the coordinating the right word, or maybe that's the issue?
Yeah.
What, tell me a little bit
No,
more.
this is Peter. I would agree with you guys that that doesn't really ring true, especially for systems like ours, where we have great communication. It's it all comes down to the policy, but I like the one that says something about hesitation by medical directors due to the employment with local hospital. They should
Yeah.
probably add another one that says politics.
Okay.
That should be like that should be at the very top of the list.
Oh, yeah. No, but let's put that behind that, and if you can get put down you know, just say you know, system-wide politics or something like that.
So this is Joelle. For we do actually have the communication with hospital contact issues sometimes when our MICNs are overwhelmed and they have too many calls and we literally can't actually get a hold of someone.
But the word
That-
maybe
that-
just communicating is what I was thinking. I think the coordinating is just didn't kind of ring with me, right? Does that sound correct? If you say, if we substitute the word communicating? Joelle?
Yeah, that would work.
Okay. Anybody else?
Yeah, Paul, we have a system whereby in some, we have stroke centres where we ring in and speak either to the stroke physician or the stroke nurse.
Yeah.
Sometimes they're not available and that causes problems and then we have to go local.
Yeah, okay, so communicating. Okay,
Yeah.
got it. That's the word. Okay. So hospital people do it under triage or under, and I heard some people say, yeah, they complain that they're bringing us too many people due to the heterogeneity of the stroke and this isn't it. Or, you know, you're not bringing us enough or whatever it might be. So listen, this hesitation by EMS members due to their employment with local hospitals, is that a common thing, or should we make it more generic? Like,
Yes.
hesitation
No,
by
no, that's an absolute thing. And the hospital system that I used to work at pulled me out of a shift to try to threaten me with exactly this problem. Because if you work at a said hospital who's a primary stroke center and you want to then bypass that primary to go to a comprehensive, they're not going to be happy with that. And if you get a stipend for that role, then that stipend is at risk. And therefore the decisions you're making are not based on patient care, they're based on your pocketbook. So it's 100% a thing.
Okay. So I would like, but I want a generic thing. Like, for example, let's say I don't agree with this stuff. I'm not going to follow these rules, right? That's a different thing. Okay. So how about lack of support from medical oversight physicians before you get to committees, right? And then, you know, and then it says committees, like, insert physicians, committees.
Paul,
Yeah.
it's not the lack of support from the physician. The physician may know that's the right thing to do. They're just not doing the right thing.
No.
So it's external influence on you know, upon the physician,
Yeah.
upon the EMS physician.
But I'm saying in this next one, underneath the hesitation by EMS medical directors, I'm saying that there's lack of support from medical oversight committees. I was just saying lack of support from medical oversight physicians / committees / groups. That's all I'm talking about. I'm not changing the other one.
Oh, okay.
Got it?
Okay. Thank you. Yeah. I'm driving. Sorry.
Get that, Akita? Got it? All right. And then we added politics, etc., and then other. All right, let's
Yep,
get through.
I'm taking notes, but I may lose service, but I am taking notes for now.
Yeah, there you go. Additional training for, go ahead. Anything else before I go to the next one? All right. And then what resources or support would help your agency better implement the guidelines? Additional training for first responders. Everybody probably checked that one. Increased transparency to hospital stroke center. Yeah, I like that. Improved coordination with receiving facility. When we say improve coordination and communications with receiving facilities, how's that? Funding for transport. Go ahead, Peter.
Yeah, Paul. I think there's one thing missing from this list, which is maybe the most important thing in my opinion, which is data transparency. Yeah. Which is what we've accomplished here in South Florida, in Florida in general, with the registry. But if we don't have transparency of data of outcomes, then nobody will ever change their actions because there won't be any perceived need to make the change, right? Yeah.
Yeah. Okay. Yeah. So capabilities and Yeah, and should we add just, or it says capabilities and data, or should we put increased transparency of data and hospital stroke center capabilities? Or do you want to create a whole new thing that says data?
Yeah, because I think the outcome data is what I'm getting at rather than capability transparency.
Yeah, so
All
let's
right,
do,
right.
we'll put that there, then say increased transparency of in-hospital data and outcome data. Because you also want to know, did they do this and what was the timing of it, that kind of thing, right? Because that's kind of in a way, it's an outcome, but people think of outcomes as, that they survived or whatever. But you really want to know how fast they got to the lab, right? Or how fast they gave TPA or whatever it might be, right? So.
Right. And then there's one other thing I would add. Sorry, I'm hogging the mic here. But we actually forced either DMV or JCO certification, because prior to that it was very haphazard and there was no teeth into it. With DMV or JCO, it actually forces the hospitals, because they get evaluated and reviewed for that certification on a routine basis. So that would definitely help implement these guidelines.
So what you would say is enforced, enforced, right, well, what's the right word? Regulation or enforcement?
Required use of external certification at the stroke center.
Okay.
Yeah, see it. Look at that. There you go.
That's why
Texas
you can
people are
hear
so
him on,
smart.
he's on here, man. He's always.
That's right.
David, anything else you would add to this? Are you okay with this so far? It's
Yeah, so far so good. One thing I would like to add is, so it says additional training for first responders / transport personnel. And the reason why I bring this up, and this might be a topic for the next one, but we're struggling with the interfacility transfer. STRAC is 22 counties. It's 6 hours across to drive. So we actually get patients from home to first hospital and then to the comprehensive place. And we are struggling with the documentation requirements. Speaking of DNB and the American Heart Association, our comprehensive are getting dinged because their patients are coming from other hospitals. We don't have the picture in the middle, right? We don't know, was their blood pressure controlled? Were they monitoring for anaphylaxis or angioedema from TPA? Were they doing an assessment along the way? And they actually got dinged because they don't have the data from the middle, right?
Yeah.
So somewhere on here would be additional training and resources for interfacility transports.
Okay, first part, well, let's say for first responders, transporters and interfacility transporters.
Yeah.
Those three groups,
EMSA,
those are
yeah.
3 different groups,
Yeah.
depending on your interpretation of what a first responder is, okay?
Hey everyone, this is Pankaja. Thanks for inviting me to this group. Fantastic meeting and a lot of learning. I'm a stroke neurologist and neurointerventionalist, and Brajesh and I go a long ways from the days of her training. I practice in New York, and this interfacility transfer is a big problem in areas outside of city for different challenges than the ones within the city. So, this question is key because for us, it's over 10 hours of transport time from one facility to other. It's not because of the door in, door out problems within the hospital that are requesting the transfer. So if there's any way to capture that information and see what we can do, because it speaks to lack of resources, and that might be something that this questionnaire may also be able to shed to use as fodder for what we want to get out of getting this information.
Yeah. So I've been missing the chat, so I don't know if I missed anything, but does anybody else think we should change or add anything to that survey, and you're ready to do it within the next couple of days over the weekend? Because I want to get this information collated and sent out. Now, if someone submits it, where does that go to? Do you know? Who's going to receive this information? When that survey goes out, does it go to Brajesh?
Yeah.
Peter?
Yeah, Paul. Yeah. Brajesh, he kind of made it on a form creator type of thing, like a Google form creator. So he's part of SVIN, very involved, and so I think it's going to be going to that entire group so that they can make use of it, potentially publish it.
All right, that's fine. No, I don't have any problem with it. Just what I wanted to do was just make sure that I just wanted to make sure that it was done, and then it's collated properly. And then I also like to know, in that circumstances, what the results were, so we can report it back to this group. Because if they're doing it, we want to know the answer to what we all found during that thing, and then the interpretation. And then I think we made it a thing, we made it that we will try to make sure that those respondents will be listed in the like an appendix as well, and we may have one or two of us that are going to be part of the writing team as well for that thing, so we'll get some credit for the Eagles as well for doing this. And I think that's the plan. Is anybody else want to add anything? Now, are you guys okay? Did you get what you needed to know then for today? From your point of view, for SVIN, have you guys got what you needed for today from us?
No, this has been incredibly helpful. Thank you very much, because this really does shed light on gaps. And the hope is that, you look at the stroke data and you look at the country, the general sentiment is that any individual living in the US is within 60 minutes of a thrombectomy center. But they clearly are not coming in that time frame. They're coming many hours down the road from when they can actually benefit from this. So hopefully this will give us areas that we can actually pick apart and focus to improve how we can actually get the patients to the treatment that they need. So this would be a fantastic first step.
So is Ankita gonna collate that stuff and just resend it back to me, and I'll just double check that it looks okay wording wise. And I like to send this out over the weekend, get it done. You guys will have results, because I think you have meetings next week and I want to have your answers for you by then. Okay. And we want to report next Friday as well on what we found with the survey. Okay.
Thank you so much.
All right. And you'll communicate that to her, right? There's so much in the chat right now. I'm just like, whatever, I'm going to leave it alone. I'm not going to go into other topics here, but does this sound okay to everybody so far then? Okay, thank you for your help today getting this done. There was one question that came out the other side. James, let me just quickly get you over what the question or comment was, if you don't mind. You may look and see if there's a thing where it says we're putting you on as a panelist. I don't know if you put it in the chat and not getting a response there. Okay, well, let's leave it at that.
Sorry, if the comment was meant for me, should I put my name and email, or is it for somebody else?
No, it's okay. It's someone else I'm trying to get over, but they're not responding there. Okay, Russell said, by asking the medical director's name, you'll get volunteer bias in the survey, and it might be more meaningful if it was anatomized or perhaps by aging. Is that right? Is that categorized? It's supposed to be?
Autonomized.
Okay, huh? What is it?
It's supposed to be anonymized.
Oh, yeah. Oh, God. Okay. Thanks, Russell. All right. Well, all right. So let's go on from here then. Okay, great. How are you doing, by the way? How's things in El Paso, right? Okay.
Getting hot.
Oh, yeah, that's right. So, yeah, yesterday at 4:01 a.m. Central Time, are you on Mountain Time or Central there? I can't remember.
We're on Mountain Time here.
Yeah, that's what I thought. So anyway, so it was at 3:01 a.m. yesterday when the vernal equinox occurred. I always love it. I used to have vernal equinox parties, so all right. So because we were even-handed at that time. Alrighty, so let's then move on. And then next thing is I wanted to introduce Will Ferguson, who's going to be joining us, correct, Will? It sounds like you're going to join us in Florida in June, correct?
Yeah, that's the plan.
All right, good. And Will's from and has been at it for a little while out in Birmingham, is joining us now, and just wanted to make sure I said, hey, can you tell us a little bit about you and a little bit about your system and all that? And so if you don't mind, take it away.
Yeah, sure. So Alabama is divided into 6 EMS regions. The BRIMS region is the one that I'm over. It's 7 counties. We have a little over 20 hospitals, 2 health systems, and a few odds and ends in there. We do about 220,000 patient transports, so about 300,000 patient touches. The cool thing, you are talking about strokes, we actually have a statewide stroke system. So we track strokes from first patient contact all the way through the ER to the ICU to rehab. So it's pretty easy for us to find the appropriate location. It's also pretty easy if we have a stroke that gets to a lower level stroke center and needs to move up. It's one call, gets them fixed and gets them moving. So it's pretty nice. Same thing with trauma statewide. We can track from the street all the way to rehab if there's survival. And then STEMI, we do regional STEMI. We've had difficulty getting the statewide cardiology group together to get a statewide STEMI system, but we're almost there. The BRIMS region, we have about 1,500 medics. There's about 3,000 in the state. We have about 10,000 licensed EMSP providers as well. Some of the cool things we're doing is currently with affiliation with UAB Med School, we're teaching a first-year EMT program to these guys. So we have a class of 40. It's a co-enroll. They meet one night a week, and we're doing that twice a year now. And these guys get 48 hours of clinical in the Birmingham area with the EMS providers, the fire department, and some time in the ER. So, you know, kind of doing two things with that. One, we're prepping these physicians to see the need for the EMS physician when they move on to their select subspecialty, whether it be ER or OB or psychiatry, whatever they do. And then the other thing is we're giving them skills they can be successful in third-year clinical rotations. So these folks are out there actually helping do cardiac arrest management using the Lucas. In our state, the EMT can use blind insertion airway devices, so they're doing that. So a lot of good feedback with that. We have a second-year curriculum with the med students where they do a week, one rotation a month with the Birmingham Fire, and it's a case study series. And then we're lucky enough to have support from our ER program. We get about 36 residents total, and they give me 1 or 2 a month to do EMS work. So good stuff going on there. The other thing we're doing from physician.
Let me interrupt for a second. So
yeah,
just in general then, what's the population of the city of Birmingham, let's say residential population? I know you probably have daytime, you probably have more people coming in, right? But what kind of, give me an idea about Birmingham itself.
Yeah, I don't make me guessing that. I'm not sure. So the city of Birmingham gets pretty busy in the daytime, but the 7-county area of BRIMS is pretty big. I would say, you know, 1 or 2 million, but that's just a rough guess. We'd have to Google that.
Good. Okay. And then you gave us an idea about how many medics you have and all that. I just wanted to get an idea about the demographics a little bit. So that's great. So I'm sorry to interrupt you, but one other question. So you got great people at the UAB in terms of the surgery department, right? And you got and you have, and from what I understand, have good relationships. I heard good things about you from them, like John Holcomb and so on. So that's fantastic. Just to put that in perspective, etc. And then, okay, go ahead. And I interrupted you. Go ahead. What's the next thing?
Oh no, that's fine. No worries. No worries. We also do Con Ed for the state. So we've partnered with our state fire college. About 80% of transports in Alabama is fire-based. Not a lot of private do the reimbursement. So we do Con Ed through the state fire college as well. We're reaching about 5,000 EMS providers a year doing that. And that's physician ed, me and a couple of colleagues, and then the residents as well. And this is all free to the EMS provider. We tag them into our cadaver labs. We use the day after the residents go through, the surgical residents and the ER residents, we pull EMS in to do IO skills, chest decompression, things of that nature. So a lot of good stuff going on there. Traditional stuff, we started a whole blood program here in 23. I think we did 90 units or had 90 patients last year. We have several spots in the greater Birmingham area that get whole blood, and we're moving toward a regional whole blood program, hopefully by the end of summer. So a lot of things going on.
Sounds great. That's great. Well, I'm really looking for you to hang out with us, and it's particularly, it just, everybody will tell you, it's just like the best event because we're just all together, and it's really kind of fun. This has been great that we do this, though, and I hope you sort of have a good vibe about what we get out of this, and it's amazing. It really is on a day-to-day basis. Well, anyway, so welcome to the gathering. Actually, I've looked up, the things where you say it's a flock of geese or it's a whatever, and it's actually called gathering is the official word for when eagles get together. So which is kind of fun. So that's why we've kind of called it the gathering eagles. Secondary intention there. All right. So let's. I want to do one thing. I want to give you guys a heads up. You'll be getting, if you haven't gotten notations from. Has anybody got an invite yet from Johannes St. Q by any chance for the meeting and signing up for the hotels? Anybody here on the call? If not, I got to get her to get it out then because we got to I have decisions. Okay,
Nope.
Someone said something. Go ahead. Jim, was that you?
Just confirming, no, haven't received anything, just kind of waiting for it.
We have to, everybody's got to get their hotel rooms in by the end of the month, okay? In other words, or else the rates go up. So I just got to make sure. Okay, I got to find out what she was supposed to have sent it out about a week ago. All right, so we'll get some invitations out to the core people, and it'll probably be layered out over the next couple of days. I'll make that my priority over the weekend to make sure we get invites out to you. I wrote that thing up about 3 weeks ago, so I'll have to see what's going on. All right, and she'll be a primary communicator for you in terms of setting up the hotel rooms, and then we'll give everybody the. I do want to say is that how much I've not liked the Hard Rock. And the good news is that we are not going to be there starting next year. Okay, this is our last year there. Let me go ahead and show you. I'll show you where we're going to be going. If I can find it now, real quick. Let's see. Where are my photos? Okay, here we go. So just to give you an idea, this is me leaving on. I was leaving. I'm in the airport now. We're getting ready to take off. That's the city of Fort Lauderdale down there. And the Hard Rock is way far to the sort of to the west of us right here. But where we're going to be going is at the convention center, which you'll see where it is in a second. And there's a new Omni hotel. We won't be able to get into the Omni next year because they already booked it, but the year after we'll be in the Omni. So here's the Port Everglades where the ships go out. There's the beach over there. And again, that's Port Everglades. That's part of my area that I got to cover. But as you'll see, just as a second, as we're very close to the beach here, there's the Omni. And there is the convention center. So that's where we'll be a year from now, just to give you an idea. And the reason why I like it is that if you go there is the 17th Street Causeway that takes you over to the beach, Pier 66. It's a really cool little thing. And the final thing is that I'll show you my front yard in just a second. So you can see how close I am. And there it is. That's where I live right there. So for those of you who've been there, know it. So in any event, so that's kind of good news. But the last year one thing I did want to say is we're going to put out a thing that if you guys can have any other sources to help pay for it, we would appreciate it. Because as a group, been able to pay for everybody. But last year we actually ended up losing about $15,000 because we had a donor that usually gave to us, and they had some, I don't know if they went bankrupt or had major fiscal problems, and they could not donate this last year. So we did pretty good overall, but in general, I think everybody got paid. But if you just making sure that we don't get caught in a little bit of a dilemma this year, it's the same old question. If you can find a funding source, fine. If you can't, that's cool. Or if you have a split, some people said, hey, I'll fly myself in if you can get me the hotel room or whatever it might be. So keep that in mind as well. I'm a little disappointed that you haven't gotten any information yet, but it should be coming. And then today, let's go back to share. Okay, I got this from where is it now? I just got this from Stein. Stein, are you on with us today?
Yes, I am here.
So you just sent this to me. So we're going to be sending, I haven't edited this yet. This is me first taking a look at this, right? And it says to Eagles invitees who would like to speak or present at it, please give me 4 topics you'd like to present, up to 4 topics. You don't have to send me 4. Send me 2 or 3 is fine. In your please post 2 or 4 questions you will address whether or not you have definitive answers, right? These are the questions you will list on the second slide of your PowerPoint presentation. So we always give the classic example. If I call Fiona and say, hey, what do you got? And you said, hey, we have a bunch of strikes this year. And I said, well, how's that important to me? He said, well, what if 80% of your people don't show up to work, right? And you go, yeah, okay, that's a good question. And then you go, what if your dispatch center goes down or gets blown up? Do you have a contingency plan in case your dispatch center goes down? So those would be, so I gave an example here. Introducing a tiered response system. Is it feasible politically, logistically, and budgeted to convert an ALS system to one that has BLS and ALS? Did this change outcomes? He's good, right? Did this mitigate and resolve staffing issues and what were the key factors? And this helps me also with writing up the CME plan as well, if you do that. And also that way I know what you want to be what you're going to be talking about, so that when I come up with my funny titles, I'm on target, in terms of doing that. Okay. So that's the end. So you put your presenter name, affiliation, and then next, I guess, the rest of it's pretty straightforward. I think it's going to be pretty much the same thing as you've always gotten from me. So I just wanted to make sure that you knew it was going to be coming fairly soon, and I need feedback pretty good because I can't put I have to have every part to put the puzzle together. That's basically what it comes down to. So as soon as you can do that for me, I would appreciate it. All right. Anybody else have anything else to add to that or have any questions about that? before I go on? We'll just go around the room. Okay, hearing no objections, we'll go ahead and go around the room. So let's let's start off with Russell. We already talked, you said not much happening there, right? So I just wanted to, so I'll skip you for now. Tim Sadie, you still here from Newark? Yeah, hadn't seen you for a couple of weeks. So I just want to see if anything changed or anything new in Newark.
No, things are going well. We continue to grind forward with our projects. Sorry I couldn't make the last few, but happy to be here. We're still trying to work on blood. We're very close, held up at the state licensing level, but
yeah.
it's always another bureaucratic issue, but we should be close the next couple of weeks. So we're very happy about that.
How about you? Are you able to come down to the meeting then? Will you be able to make it?
Yeah, it looks like I have the time off clinically, so I should be able to make it.
Fantastic. Okay. Hey, now I'm seeing Michael Feldman up there. Anything you got to report to us out of the Toronto area? Or Canada in general, you know, have you raised tariffs on us yet? EMS tariffs.
I don't even know. It changes day by day. I'm just glad to see that Ontario didn't pull the switch and turn out the lights in New York State.
Exactly right. Did you ever see that movie Canadian Bacon with John Kennedy?
I saw it years ago.
Yeah, I remember because they were going to put down the whole grid, and there was a mom and pop, she's sewing and knitting or something like that. You're like, it's so great about the stereotypes about Canadians and U.S. people, right? I love that one scene. He's driving along in a truck, and it says, you know, something like "eat whatever," you know, just it was all this like really nasty stuff about Canadians, right? And then they get pulled over by the cops, and he said, "We have a law here that you have to have it in French as well." So they put up all the stuff in French as well. It just was a funny scene with Dan Aykroyd. It was really good. Yeah, so if you haven't seen it, you got to check it out again, because I think the stereotypes are just as good as ever and more appropriate nowadays. So it's good. But anything new to report though at all, Mike?
I put something in the chat earlier for a potential future topic to look into. It's not very exciting. It's not an emerging infectious disease. It's not blood or blood products. But it comprises a big part of our work for EMS system. We're just halfway through a changeover in the province of Ontario, population about 16 million, to MPDS. And we also use MTPS, the Medical Transfer Protocol Suite, for call taking for interfacility transfers. We still have a lot of challenges in really getting the priority right. When you have a Delta in the community, and you know a ruptured AAA in a small town hospital, and you have one resource to send at that time of day, who gets the ambulance first? So I'd be interested to hear maybe at a future session, or maybe even have a survey of how do you balance the interfacility transfers? How do you arrive at the right priority? The level of care seems to be a bit easier because that's simply procedures and drugs, but I'd love to hear what other people do. This is such a great venue for cross-pollination, and I love the ideas I get out of here.
So I think, and we heard that issue with the stroke that David was talking about before, right? And yeah, whatever. And then the use of 911 system to do, like, for example, you know, Clayton is saying the same thing. So let's bring that up as a topic. Remind me if you want to do it next week. We could just put that on as just remind me, and I'll put it on as a topic, and then we'll have a cross-pollination talk. Okay. Sounds like a good plan. So why don't you open it up and tell us specifically about it, like in a 3 or 4 minute opening session, then we'll have a conversation about it and see, because it sounds like there's 3 or 4 other people having problems maybe in some specific areas. So it all has to do a little bit with, you know, what the availability is there. Peter, like right now in Brevard County, do any of our folks do the transfers, or is that all done by Coastal, or how's that work, for example? Are you there, Peter, still? I don't know if Peter's still on. We were talking about this yesterday, that's why. The issue. And then, okay, let me then jump up to if Peter's not on, let's jump up to New York. Glenn, how do you do that? In a hospital, are they done by the hospitals themselves, or is it done at all by FDNY?
Yeah, we actually have a stat transfer in our call type, but I tell everybody it's not stat, or, you know, it's really, you get a BLS unit. We just provide the vehicle. So if you need any higher level of care, the facility has to send a nurse or physician, whatever level they have to. Some of the smaller hospitals, they just can't. So we tell them, you can contact us. It's not stat. And contact your private vendor, because that's a requirement that they have to have a transfer agreement. And if we get there first, then we can do the transfer as part of our 911 call, but we routinely do not do it.
So I think just jumping ahead, I think you're going to see so many different models, Mike, that it all depends. But maybe, you know, whatever, maybe we can learn a lesson from each other and all that. Let me jump over to Nick. What do you guys do? Does the ambulance, National Ambulance Service handle that, or do you have other private services that do it? How does that work?
Sorry, private service that offer to cover what, Paul?
For inter-hospital transfers.
So it again, very variable. So the National Ambulance Service will do the most critical ones. We have what's called a Protocol 37. Somebody has to be there as soon as possible. What they will guarantee you is the closest vehicle. They don't guarantee you a certain level of a pre-hospital provider. So the hospitals are obliged then to staff the ambulance with medication and drugs and appropriate trained personnel, particularly if you've thrombolized or if you've got people on blood or other pressor supports.
Yeah.
For routine transfers from wards, the problem is the ambulance service is overly stretched. My hospital doesn't have a cath lab, so we have to transfer out to get people to a cath lab. So they come in with a non-STEMI and are going to get a cath in the next couple of days. We will book National Ambulance, but they will very frequently, half an hour before the journey time, say we can't deliver. So we're now obliged to use a private provider and fund that ourselves to make sure the patient gets to the right destination. Otherwise, their cath will be cancelled. And that happens quite frequently. So it's more of an issue in the rural areas because there aren't the bigger resources. The more you get to an urban area, there's a lot more assets floating around. So they're able to respond to those transfer requests.
So Mike, my point is that there's going to be so different models, different things about what's happening in the different restrictions. So it'll be interesting to see and hear, but maybe we can learn from each other a little bit during that discussion. So we'll open it up more next week. I just wanted to sort of throw out and give you kind of a preview of what I think you're going to hear. Okay.
Absolutely. I'll send maybe some thoughts or points for discussion that I've been thinking about. The interesting thing is the literature around this is very scant.
For some of the reasons I just stated. So that's right.
Just add one more thing. We have almost zero capability for helicopter transfer. So
right.
that is not an option. This is nearly all 99.9999% road.
Yeah. And it can take a while to get across the country too, if you have to go down to one of the neuro centers or something for like
it's 4.5 hours from Donegal to Beaumont.
Yeah. Yep. All right. So okay, so let's do this. I think we'll have that as a plan. Just remind me, hey Mike, are you able to come to the meeting in Fort Lauderdale, or do you want to come down to it?
I don't believe I'm able to, but I'll have another look.
It's the week of June 9th, just so you know that all those, you know, our meetings are on the 10th, 11th, and 12th. Everybody comes in on the 9th usually, okay? Unless you want to come down and hang out in Fort Lauderdale for an extra day or two, or before or after, that kind of thing. All right, let's just bomb around the room real quick. Okay, Will, we know about what's happening with you. Tim, we talked to you. Stein, anything out of Colorado Springs? I'm sorry to catch you off.
No, nothing new with me.
Okay, good. And I'm excited. This is gonna be a really cool thing we're gonna do in May. I thought it's gonna be really fun. Thanks a lot. Shay, anything else do you report out of Denver from your point of view?
Sorry, Paul, not too much, just a bunch of events going on downtown that we're preparing for. But really that's about it.
All right, got it.
Big going on.
Hey, Matt, Levy, anything going on from your end? Just happen to see you there.
Yeah, hey Paul, sorry, at an airport. Good to see everybody. Nothing really to report. Thank you.
All right, I'll see you in a couple of weeks. It's gonna be fun. It's gonna be great.
Absolutely.
Yeah, and good because you'll be there for Trauma Day too. That's what's even better. All righty, so Libby, anything report out of? I skipped Rob Lowe. Let me go to Rob first. Rob Lowe, anything out of the Columbus area?
Nothing spectacular. Been having some good headway on trying to do some fundraising for blood and all of that background setup. So,
Okie dokie then. Thanks a lot, John. Anything from Portland to report?
Nothing from Portland.
All right, got it. This is great. We'll get through this pretty quickly. Jacob, anything else to add? Jacob, not, and then I'm going up the list just so you guys know.
No.
All
Nope.
right. Okay, Glenn, anything to report from New York?
Luckily, nothing major, but one of our major hospitals that was slated to close next week
Yes.
just got a stay of execution by the courts to say you can't close yet. Apparently, somebody filed another injunction, something, and the paperwork wasn't complete. So now they're waiting for the judge to tell them it's going to go ahead and be looked at again or go ahead and close. So everybody's kind of in limbo. It's Lower Manhattan, so Bellevue, NYU, they're close to that hospital. They're very, very worried about the call volume. They're going to close. Inevitably, they're closing.
Which
This hospital's
place
losing money.
Is it a Sinai? Which one is this? Which one?
It's Mount Sinai that took over for Beth Israel. So Beth Israel is the hospital that's closing.
Yeah, what's it called? Sinai what? East or something? What's it called?
No, that one's called Mount Sinai Beth Israel. They
Mount
kept the
Sinai.
Beth Israel name. Yep.
Okay, that one. Okay, got it.
It's a major hospital, so.
Yeah. Was it a stroke center? Was it a STEMI center? Was it a what?
It was both, yes.
Okay, so it's
And
going to have an
psychiatric
impact
patients.
on Bellevue then. Okay, got it. So we're undergoing the same thing. I think we told you in Brevard County, and that's a hospital that was a receiving center. Now we're going to have to transport people with some of those conditions almost 40 minutes now. And then you have to get back to territory because we're a fire department based system, So it's going to be we're going to face it now. Will have an impact on you guys, I guess so, right? Because you're going to be maybe have an overcrowded Bellevue and you can't offload the patients, or what do you think? What do you think?
There's going to be a lot of issues, absolutely. And that hospital also put out a couple of ambulances in the 911 system as well, so they're going to be gone.
Okay, got it. Like in our situation, we're going to lose the helipad there. So so there's a lot of different challenges there. Okay, got it. Alrighty, Ben or Jenny, anybody there to talk about Baltimore?
Nothing to report, Paul. Thanks again for the conversation.
Okay, good stuff, right? Clayton, you guys, do we need to talk later, or is it, or I'm coming in Sunday afternoon, right?
No, you're coming in Sunday. Mark texted me because he can't be on today and said because we've been going back and forth on some other issues that we need to connect just to make final arrangements for you.
Okay, got it. Don't say it that way. Final
arrangement. No, not that kind of final arrangement.
All right.
I put in the chat.
Something I don't know. Did you talk to my
I put in the chat an interesting article for folks to read about a Ninth Circuit Court of Appeals decision. If you don't know about it, you should read about it. It happened last year.
Okay, what is it?
It basically, the Ninth Circuit Court of Appeals said that law enforcement loses their qualified immunity when they're handling a patient, for example, a mental health patient in whom they're applying force, but the patient is not breaking the law. So in response to this, the Sacramento County Sheriffs up in Kevin's area, and actually Kevin texted me asking me to bring this up on the call. Sacramento County Sheriff said, we are no longer responding to any mental health call unless the person is breaking the law. And we are getting ripples all across our system of other agencies, other police agencies that are aware of this decision and wanting to meet with us to discuss mental health response. So whether this goes to the Supreme Court or not, I don't know. It probably should. I don't know if it will.
Okay. Can you and or Kevin do a presentation on this next week? Let's drill down on it a little bit more, because
I'm going to commit Kevin since he's not on the call.
Okay, that's fantastic. Yes. Good job. Okay, good. All right, Matt, you had something to comment to make about that?
Yeah, sure did. Clayton, maybe I can connect with you and Kevin offline. We've been living this very complex altered state of existence for about 2 years in Maryland because of a local repeal of the Law Enforcement Office Bill of Rights, and we're dealing with this. Ben and Jenny are on as well. We can tell you, easy is not the word I would use to describe the situation. So this has been a familiar space for us in parts of the East Coast, so maybe we can be of some help with some ideas. I don't know that any of them are good, but at least talk through where we're at with stuff.
Okay, got it. All right, so then let's have a thing where maybe you guys can join in and do a secondary presentation, Matt, to that, if you don't mind, next week. Okay, so all right, that's interesting. Well, thanks, Clayton, for the good news. He said ever so sarcastically, right? So all right, let's see, who have I missed here? Bill, while we're in California, anything to report out of your end besides
no, we're just winding down a big flu season. I saw that CDC reported this flu season 23,000 deaths from influenza, and about 41 million cases. So hopefully, as spring comes, we're starting to get resolved that problem.
David, anything from you?
Yes, actually, I'm typing a survey question actually as we teach. So in my system, we have had a change of chief and a change of EMS chief, and they're questioning everything we do. And what came up was credentialing. So you have a new paramedic that comes out of school, passes the registry. Now what? So we've had a process of 7 shifts and an evaluation by one of our staff. And then they come for a medical director interview. What we're finding is that's totally insufficient. So like in Austin, you ride for a year, right?
Yeah.
I know I did months and months and months way back in the day. So I'm going to develop a little survey and find out how my brethren are credentialing new paramedics, because I'm going to fight with my chief. And
he understands the issue that as a doctor, I got my MD license. That's like the state certification, right? As a doctor, I sat for board certification or whatever, and then at the hospital, I still have to be credentialed, right? So they, that's typical in medicine. They understand all that stuff, right?
Oh, yes. And in Texas, it's a delegated practice state, and which was reaffirmed just recently in the state legislature. So either I say yes, or they don't go in the truck.
Right.
And so, but the problem is budget. So this is all about overtime. It's all about overtime. I want these guys on the street, right? Because they're riding third.
Right.
So overtime. So anyway, it's a big deal for them money-wise, and they're getting a lot of pressure from the non-medically trained fiscal smart person in the city government. So I have to give them a little juice. So the good news is that we're finding the 7 was never a good idea. And that we're looking more at 10, 24-hour shifts.
Yeah.
But we also layer on that. We look at what runs they've had. We send one of my civilian training officers out to evaluate them in practice on the truck. And then they come for the medical director interview, which is about, a half hour, 45 minutes of interrogation by Papa Bear.
I'm going to tell you what I used to do. I had a jury of their peers. So what I would do is bring in some of the really good paramedics that we had. I would bring in some of the supervisors, and I'd take them through whatever. Then at the end, I'd sit there and say, okay, what do you guys think? Would you let them take care of your mother tomorrow? And that was the ultimate thing, is that would you let this person take care of you? That kind of thing, et cetera. And so, but it was good because then it wasn't just the medical director. It was, a jury of your peers kind of thing, right? So
we actually include that. So we have 3 levels. So the training officer evaluates them every shift. And there's special dudes that do that, and dudettes, right?
Yes.
I send a civilian training officer, someone from my office, to look at them and say, yep, they're ready to go for you. And then the 3rd level is me. And then, or one of my partners.
Okay.
We actually, what we're finding is like 3/4 of the people that we bring in the office, we have to send them back out because they haven't had the critical runs in order to really evaluate their ability to practice.
Yeah. Okay. All right. Okay. It's good. Well, then start putting that together, and we'll see what do you do. What's your process? I guess but that maybe that's a panel we do, or maybe let's do this at Eagle Creek. Maybe, if you remind me, it'd be a good one to go around the room and see what people do and what they think. Unless you need to get it done beforehand because of.
Well, we'll do the survey and then we'll talk about it.
All right. Got it. Okay. Good. All right, who have I missed? Anybody? I'm trying to see if there's anybody I've left out. Libby, anything to report out of Hawaii V?
Nope, all well, all is well here.
All right, good. All right, I think that's enough. Unless I missed someone or anybody wants to put in. Jim Augustine, go ahead, sir.
Okay. Clayton just sent out that position paper from NAEMSP on criminal liability. That was a joint statement that went out to everybody. And then,
oh God, I wanted you to talk about that, didn't I? Can we do that next week as well?
Clayton is prepared to talk about it. And I just wanted to say very, very short, Ken Shepke, Peter Antevi, and others' paper on ketamine in seizures was published yesterday.
Amen. Amen. Because let me tell you, the pediatrician said, there's no data, there's no research. I shoved that right in their inbox.
Okay, what it came out, what paper was this? I'm sorry.
Ken Shepke's paper in Annals of Emergency Medicine on ketamine use and seizures.
Oh, okay, got it.
And so it went into your mailboxes, everybody, and we can discuss it later. And then Clayton was prepared to discuss that joint position paper.
Doug asked me, he texted me on the side saying he couldn't be on the call and wanted me to make sure I shared it also with this group.
Okay, so what we're talking about is then criminal liability issue, right? Okay, for Clayton, right? Criminal liability. I'm just trying to put down what we're talking about next week.
Criminal liability for medical error.
For med error. Okay, got it. And then what was the other thing we had from Mike Feldman is going to do interfacility transports, right? Interfacility. I'm going to try to stay because it sounds like we got a lot of topics already for next week. Interfacility transports, okay. And let's see, what was the third thing we were gonna do? I can't remember. There, geez, I've already forgot. I told someone to say, remind me, we'll have you on. Like in-facility. What was? Does anybody remember what the other topic was? Criminal liability.
Was it credentialing that Miramontes was talking about?
I guess. Okay, we'll do that, credentialing. Okay, well, I'll put that down anyways, right? Okay. Miramontes credentialing. There seems like there was something else I forgot that I heard, but that's what I'm saying. That's why I told people, remind me and I'll put you on, that kind of thing, right? Okay, so I should write them down right here and there and take care of it. Okay. All right, that's it from my end. I got a bunch of I got a couple twins in the other room that need my attention, so I'm going to head over there. And Lauren is coming out hopefully on has her second baby's coming out on Monday, so I'll be a quadruple grandpa by next week, I hope. And so we'll see everybody later. And if there's anything else I can do for you all, let me know. We'll see you later. Take care. Bye-bye.
You're looking good being at that stage, Paul. Congratulations.
So say that again. What?
You're looking good being at that quadruple grandpa age.
Oh yeah, right, exactly right. So yeah, I had all my doctor's appointments. I had a retinal tear last year, and I said, was it because of some underlying disease? No, just this stuff happens. It wasn't traumatic or anything. So, and they fixed it. I'm fine. So all my eye pressures are good. I'm still 20/20 and all that, except for reading glasses. They said I said, well, it's not normal vision. I got to use things to read the little small print. And they go, yeah, you're normal for your age. You got presbyopia. So that was kind of interesting. And so, and all my everything else looked really good. Whatever that called, A1C was 5.3, and my prostate levels were down. So I was like, I'm in good shape. I think I can make it for a couple more years. We'll see how it goes. So, but thanks for everything. All right. Well, listen. And by the way, thank you all for their commentaries about about this thing, because we really have a unique form of continuing medication credit, and I want to make sure we sustain it for you, because it's amazing. I mean, I get what is it we get every year? If it's 2 hours and I'm on for it's at least 80 or 90 hours of continue, and it's better than I could go to a meeting all day long and not get as much out of 15 minutes with you guys, that kind of thing. So it's fantastic. So thank you so much, everyone. Take care. Okay, welcome back, my friends, to the show never ends. Next week, that would be March 28th, the last day that we'll still be on 4 hours away from Mick on the East Coast, right? Right. All right, Mick, see you later. Take care.
Thanks, Paul.
Did you see your president's comment on the daylight savings time?
Oh, what was it? I don't know. What was it?
He didn't understand why Europe still did this. They're just asking Granny to die an hour earlier than everybody else, and you don't realize that in your families.
It's so embarrassing, but well, whatever. So we'll leave it at that. It's like flock immunity, right?
Well, Rome was fantastic, I have to say. I came back absolutely full. The food everywhere we went was amazing.
Oh, that's fantastic. Well, welcome back. I'll see you later. Take care. Bye-bye.
Okay. Good luck. Good night.